Endoscopic ultrasonography-guided deployment of embolization coils and cyanoacrylate injection in gastric varices versus coiling alone, a randomized trial. Introduction. Bleeding from gastric varices is more severe and life-threatening than bleeding from esophageal varices and is associated with high mortality and morbidity rates. Management of bleeding from gastric varices is challenging and requires expertise because aggressive rebleeding can occur. Treatment of varices by injection of cyanoacrylate via standard gastroscopy is associated with a higher hemostasis rate and a lower rebleeding rate than either band ligation or sclerotherapy, but has been associated with adverse events such as pulmonary embolization, bleeding, fever, chest pain, and even death. In addition, the endoscopic injection of cyanoacrylate has been shown to result in damage to the working channel of the endoscope. Moreover, complete variceal obliteration is difficult to confirm during the procedure and may require additional therapeutic sessions. The use of endoscopic ultrasonography, EUS, to guide the cyanoacrylate injection has several advantages over guidance by visible light endoscopy. These advantages include the precise targeting of the feeder vessel of the gastric varix and the requirement for a lesser amount of cyanoacrylate for obliteration, which is an important consideration because the risk of glue embolization is dependent on the volume of cyanoacrylate injected. In addition, EUS evaluation can confirm obliteration of the varix via Doppler imaging after the procedure. The EUS-guided deployment of embolization coils within gastric varices is associated with fewer adverse events than EUS-guided injection of cyanoacrylate, but has the disadvantages of a lower obliteration rate and a higher cost. The combined injection of coils and cyanoacrylate was first described in 30 patients and resulted in a 95.8% obliteration rate. In a larger cohort of 152 patients, this combined approach showed a 93% obliteration rate with a 3% rebleeding rate. However, in this retrospective study, only 65.7% of patients had an EUS Doppler study performed to evaluate complete obliteration. There is a lack of prospective data comparing EUS-guided coiling and cyanoacrylate injection versus coiling alone, with a focus on the obliteration, rebleeding, and adverse event rates to define the most appropriate obliteration technique. The objective of the present study was to compare the efficacy and safety of EUS-guided combined deployment of coils and cyanoacrylate injection with EUS-guided coil deployment alone for the management of patients with gastroesophageal varices type 2, GOV2, and isolated gastric varices type 1, IGV1, in a prospective randomized controlled trial. Methods: a single-center, parallel randomized controlled trial involving 60 participants with gastric varices, GOV2 and IGV1, who were randomly allocated to EUS-guided coil embolization and cyanoacrylate injection, N = 30, or EUS-guided coil embolization alone, N = 30. The primary endpoints were the technical and clinical success rates of both procedures. The secondary endpoints were the reappearance of gastric varices during follow-up, along with rebleeding, the need for reintervention, and complication and survival rates. Results: the technical success rate was 100% in both groups. Immediate disappearance of varices was observed in 86.7% of patients treated with coils and cyanoacrylate versus 13.3% of patients treated with coils alone. P less than 0.001. Median survival time was 16.4 months with coils and cyanoacrylate versus 14.2 months with coils alone. P = 0.90. Rebleeding occurred in 3.3% of patients treated with combined treatment and 20% of those treated with coils alone. P = 0.04. With combined treatment, 83.3% of patients were free from reintervention versus 60% with coils alone. Hazard ratio 0.27, 95% confidence interval 0.095 to 0.797, P = 0.01. Conclusions: EUS-guided coil embolization with cyanoacrylate injection achieved excellent clinical success with lower rates of rebleeding and reintervention than coil treatment alone. Multicenter studies are required to define the most appropriate technique for gastric variceal obliteration.